NTF difficult to treat TB clinic. I take this opportunity to welcome team from Center TB Division, our DDG Sir Dr. Joshi and his team. Dr. Joshi would not be able to join us today because of some work travel. A very warm welcome to all the state TB officers, district TB officers, faculty from medical colleges, and all the participants who are attending today's clinic. It is my pleasure to introduce today's clinic. To my right is Professor Dr. Rupa Singla sir. He's HOD TB and RD at NIT RD, and myself, Dr. Saroj Meena, chest specialist at NIT RD. And we have been joined by our director sir, Dr. R.K. Divan. It is the first time. Today will be discussing an EPTB case. The case has been worked up by the Hyderabad team along with the team from LB Prasad Eye Institute, Hyderabad. Now I request our director, sir, Dr. Divan, sir, to give his opening remarks.
Thank you, Dr. Saroj. Thank you so much. I welcome all the delegates who have taken pains to join this meeting. And as I have been telling in earlier occasions also, this eco clinic of difficult to treat TB clinic is one of our flagship initiatives, which is catching on every month and is attracting attentions. And one thing which we have noticed in the national task force, in which is a medical college, I mean, all the medical colleges joining hands in our fight against tuberculosis, that faculties of medical college have also to act in tandem with the National TB Control Program. So this case, especially, I'm very happy to note that this case is from, you see, has an ocular presentation of some ocular disease presenting as tuberculosis, a very rare and unusual case. So it will generate further interest, and it will also further reinforce the idea that whoever our respiratory or TB specialists in various medical colleges, they have to sensitize other departments about the optimal and best possible TB treatment. That will yield the maximum results as well as earlier achievement of our goal of ending TB. Thank you so much for asking me, Dr. Saroj, and I welcome all the delegates and looking forward to fruitful and enjoyable discussions. Thank you.
Thank you so much, sir, for your kind words. I'm happy to welcome Dr. Shakil Hammer. He's a professor from our Bangladesh team. He's director MBDC, Bangladesh. Sir, welcome to our Eco Clinic.
Thank you very much. Thanks a lot.
So the address.
Thanks, Dr. Shakil, for joining us. Thank you. We welcome you on behalf of India also. Thank you.
So we'll be directly moving towards the case discussion. Today's case will be presented by Dr. Soumya Basu, Consultant Head, Uveitis Services at LB Prasad Eye Institute, Eye Institute, Hyderabad. We also have Dr. C. Sumalata. She's a state epidemiologist, STDC. She'll be our state expert for today's session. And our special invitee, Dr. Shishir Narayan, Consultant Uveitis and Ocular Inflammation, Shroff Eye Center and Director Eye Trust Clinic, Manipal Hospital, New Delhi. He has a special interest in infectious uveitis, tuberculosis, toxoviral uveitis. He has very vast experience in treating ocular TB and have many publications to his credit, especially as a member of CORD's Collaborative Ocular Tuberculosis Study Group. Welcome, sir. We'll begin with our case presentation. Dr. Soumya Basu.
Yeah. Thank you. Thank you so much for the invitation to speak at this forum. I'm most glad that ocular TB has been given such a huge platform at a national stage where we can present it to non-ophthalmology community. And I seriously thank Dr. Sumalata and Dr. Rupak Singla for giving us this opportunity. So I will be presenting how ocular TB can act as a window to systemic tuberculosis. Unlike the other way around, which is how we expect it on most occasions, that we diagnose systemic TB and then find something in the eye and then call it ocular TB. It's the other way around in our patient today. So I'll start with a brief introduction to ocular TB, then present the case, and then discuss about the drug resistance patterns in extrapulmonary tuberculosis in general. Now, ocular TB is an extremely paucibacillary infection from Mycobacterium tuberculosis, and it has multiple clinical presentations. I think this wide range of clinical presentations is something to be understood very clearly, especially in the non-ophthalmology community. The other important point is that it very frequently is not associated with any pulmonary or extrapulmonary tuberculosis. So you were just mentioning about the COTS data, which is the collaborative ocular TB study, where 945 patients from all over the world were included, and 92% of these patients with ocular TB did not have any evidence of active pulmonary or extrapulmonary TB. 77% did not have any past history of TB, and 31% did not show even an evidence of healed TB on radiological examination. So this is a very important concept that I would want our chest and general medicine colleagues to understand, because the ophthalmology community in general faces a lot of challenge trying to convince our chest colleagues that most of these patients actually do not have any evidence of either pulmonary or extrapulmonary tuberculosis. So this is a classical picture of ocular TB, which we would have all read in our textbooks. That is choroidal tuberculoma. You see the picture here. You can see the blood vessels passing over the yellow lesion over here, which shows that the lesion is very deep in the choroid. Then there is this new entity, and we must know about this entity, which is called as serpiginous-like choroiditis. It is called serpiginous because the edges of these lesions extend like a serpent or in an amoeboid fashion, and therefore it has been called serpiginous-like choroiditis, because the original term serpiginous choroiditis has already been taken by an autoimmune condition which was first described in the West. The one which we are talking about here, which is serpiginous-like, was described in India at PGI Chandigarh. And I'm very happy to inform all of you that after a lot of resistance from all over the world, now the entire world, not only in TB endemic, but also in TB non-endemic countries, have recognized that serpiginous-like choroiditis is a very classical presentation of ocular tuberculosis. And the third one, which is an area of big interest for me, is this condition called as tubercular retinal vasculitis. Now, unlike all the vasculitis which you would encounter in your clinical practice, you can see the perivascular infiltrates around the blood vessels. You can see all of it here. And along with that, you also see these bright lesions, which I'm pointing with my arrow. And these are actually retinitis lesions lying on the blood vessels. And this pattern of TB retinal vasculitis actually has a lot of similarity with the literature that is available on TB cerebral vasculitis. So this is a very interesting field of research in ocular tuberculosis. So these are only some of the presentations of ocular TB. There are actually several others which I'm not describing here now. So what is the fundamental difference between ocular and pulmonary tuberculosis? Again, something that our colleagues need to understand. You know very well that pulmonary TB starts with the clinical symptoms appearing, the cough, low-grade fever, weight loss, all of those bringing the patient to you, and then you do a sputum examination, get a microbiological diagnosis, treat the patient, usually without any corticosteroids, and then you can repeat the sputum evaluation and tell that, hey, you have been cured for now. In contrast, in the case of ocular tuberculosis, when the patient comes with clinical symptoms, this could be, loss of vision, which is more likely, redness, pain, in the eye. All of these will bring the patient to the clinic, most often without any previous signs of systemic tuberculosis. Then we look for all those clinical signs which I showed in the previous photographs. And if those signs are present, we test the patient for an ancillary evidence of systemic TB infection. Now, this is often an area of a lot of debate, that how can you treat a patient with anti-TB therapy just because a MON2 test or a quantiferon test is positive. Yes, we do treat based on that test, but that test is only 1/3 of our basis for advising anti-TB therapy. The first most important third of our basis is the clinical sign that we are seeing in the eye. The second part is getting any evidence of systemic TB infection as MON2 or quantiferon. And the third part is very important. It is the exclusion of non-TB entities. And in the case of ocular TB, the two most important non-TB entities are sarcoidosis and syphilis. Only after you have fulfilled all these three criteria do we advise anti-TB therapy to the patient. And majority of the patients require either topical or systemic corticosteroids along with the anti-TB therapy. Then again, we do not have any way to verify the cure, but just like you can do a sputum evaluation, we do not have that means. So we depend on the clinical resolution of the lesion with the treatment, and more often with non-recurrence of inflammation after having completed the anti-TB therapy. I hope this slide has been able to explain the fundamental difference between pulmonary and ocular tuberculosis. So the other advantage which ophthalmologists have as against the non-ophthalmology community is our ability to directly visualize the process. You can see the serpiginous-like choroiditis in the first image here, and the retinal vasculitis in the other image. And we can see this appearing and then resolving once we start the treatment, which you do not need any test to look at the response to treatment in these kind of patients. Not only that, we have various imaging modalities. The first one on the left, which I'm pointing with the arrow, is called as fundus fluorescein angiography, where a fluorescein dye is injected into the patient. I hope I'm audible.
Now you're audible. In between, for a few seconds, it went off.
Yeah, somebody muted. Okay.
But you very
So,
clear.
Yeah, please let me know if my internet connection has any problem.
Sure.
So the other two things we can do is doing this test called fundus fluorescein angiography, which is an invasive test, and then we have non-invasive tests such as the one on the right side, which is called as fundus autofluorescence. So the autofluorescence from the diseased and the healthy retina can tell you what is the progression or the resolution of the disease process or the inflammation inside the eye. So these are some of the things that I would like our colleagues to get introduced to in the context of ophthalmology. Now, the understanding of ocular tuberculosis that I just discussed with you has been very well endorsed by the different government agencies. In 2015, we had these index TB guidelines, and earlier this year, we had this standard treatment workflow for the management of intraocular TB released by the ICMR. All of this is available on the internet. I have given the website address down below, and you can easily access and see what the government guidelines are for managing such cases of ocular tuberculosis. Now, briefly, the index TB guidelines tell us that once you see a patient where you are suspecting ocular TB based on these clinical signs, you typically advise the patient for some form of ocular imaging, which I just mentioned. And then you exclude the non-TB entities by doing the appropriate tests, more importantly, sarcoid and syphilis. Having done that, you test the patient for the MON2 test or the quantiferon. The guidelines, of course, mention only the MON2 test, not quantiferon. Then you get an imaging of the chest, find if the patient has any history of microbiologically proven EPTB or PTB. And in very rare cases, like the case I'm going to discuss today, we can get an ocular tissue biopsy and show the organism directly in the eye. It's also very important for us to get a history of TB exposure. I don't know how commonly we ask for this question in the chest clinic, but for us, it is very, very important. And typical cases of TB exposure that are missed are from migrant workers. Now, remember that these migrant workers would stay in very small rooms, multiple people staying in the same room. And very commonly, they don't disclose to each other if they have any such infections, such as tuberculosis. And these are common scenarios where people pick up the infection and they may not develop any evidence of chest tuberculosis, but they come to us with extrapulmonary tuberculosis in the form of ocular TB. This is a very common scenario in our practice. So once you have done all these tests, if only the tuberculin skin test is positive, we call it as possible ocular TB. If you may or may not have evidence of PCR proven TB from the ocular fluids. Then if you find any evidence in the other parts of the body, either on a chest imaging or in, for example, the lymph nodes or GI tract or bones, then we call it probable ocular TB. And if those very, very rare occasions where you find evidence in the tissue, we call it in the ocular tissue, then we call it as confirmed ocular tuberculosis. Now, with this background, I'm coming to the case report, which is of a 20-year-old female who presented to us actually in June of last year, June 2021. Now, what happened before she came to us is that in February, So in February of 2021, she was diagnosed by the local ophthalmologist to be having right-eye granulomatous panuveitis. She also reported weight loss and low-grade fever at that point of time. To the ophthalmologist, she was tested for the Montu test and the HIV, which you can see the reports here. And a CT scan was done, which showed these multiple focal areas of centrilobular nodules in a tree in bud appearance. We couldn't get the CT plate with us, but this is what the report told us. Okay. Now, the sputum for AFB at that point of time, as well as the gene expert, was negative. And based on the above findings, she was started on 4-drug anti-TB therapy along with oral and topical corticosteroids. In the next couple of months, she did not have any further improvement. In fact, she was injected intraocular corticosteroids, but there was a complication during the injection and she developed a cataract, so therefore also underwent a cataract surgery. She was treated with intravenous methylprednisolone as well, but despite all this additional corticosteroid, she had further worsening. And therefore, in May 2021, she had a repeat chest CT scan and a repeat which was positive with the gene expert showing rifampicin resistance at this point of time. She was started on second-line ATT. You can see the prescription here. Actually, I couldn't understand some of the medications which are listed here. So I can see kanamycin, I can see linezolid, moxifloxacin, but I can't make out all the medications which are here in this prescription. However, despite all these medications, she did not improve. Now, the way we approach persistent inflammation after the initiation of anti-TB therapy is that, again, we exclude non-TB entities. Then if you have a picture such as serpiginous-like choroiditis, then we typically rule out paradoxical worsening, which I'm sure many of you are familiar with in cases of, say, lymph node or CNS tuberculosis. We check the drug compliance and the dosage, and then finally look at the possibility of drug resistance. Now, if it is paradoxical worsening, we treat the patients with additional corticosteroids while continuing the ATT. If there is any issue with the drug compliance, we refer the patient back to the physician. And for drug resistance, usually the way we find out is if the patient has any concurrent pulmonary tuberculosis, a recent contact with an MDR-TB patient, and in very rare cases, we get to do a vitreous biopsy for a gene expert or an LPS. Now, all of these things have been reported, but never before from an ocular sample has a phenotypic DST assay been reported prior to this particular case. Okay, so this is how we approach persistent inflammation in the eye after initiation of ATT. Now, this patient came to us on the 18th of June last year. Her condition had worsened further despite having received the second line ATT for nearly 2 weeks. And she had a corneal perforation, which you can see here where I'm pointing with my arrow. There were pigmented anterior chamber exudates. There are multiple nodular scleritis. You can see the nodules over here, and ciliary body granuloma, which were picked up on ultrasound biomicroscopy. We, at this point, did an anterior chamber tap. This was done by my colleague, Dr. Somshira Murthy. And this tap was sent for both microbiological evaluation and PCR. Now, this was a very, very rare occasion when the smear from the anterior chamber tap actually grew acid Mycobacterium tuberculosis on the LJ medium, and acid-fast bacilli were also seen on the smear. Furthermore, we took help of Dr. Somalata here at the state TB lab, and the sample that we had collected, we isolated DNA from that sample ourselves, and we sent the DNA to her lab for line probe assay. Okay, now this is one point that I want to highlight here, that the protocol for DNA isolation from the ocular fluids is different from the protocol that is used for, say, blood samples or even from sputum samples. So it is better that ophthalmology labs, let me change a little bit here. This is, give me a second. Yeah, I'll stop the play narration, that makes it easy. Yeah. So this is one point that I want to highlight here, that when you want to do any kind of molecular diagnosis on an ocular fluid sample, it's better that the DNA isolation is done by an ophthalmic lab which is well versed with such a process, instead of sending the sample directly to a lab which is not aware of the protocol for ocular samples. This is an important point I want to highlight today. Okay, so we send the sample for line probe. As some of you might be aware, the line probe assay is basically based on a principle of reverse hybridization, where once you have amplified the target, you hybridize it with known DNA probes, which tell you about the possible mutations in the sample that has been provided to you. Now, the advantage of the line probe assay is that it not only helps you identify Mycobacterium tuberculosis, but it also helps you in rapid detection of mutations to multiple anti-TB drugs, including second-line drugs. This advantage, as you know, is not available with the gene expert. So our line probe assay, which we which we got from Dr. Somalata's lab, told us that there was resistance to rifampicin, INH, levofloxacin, and the aminoglycosides, amikacin, kanamycin, and caprimycin. Now, at this stage, we actually called it pre-XDR TB, but if you look at the definition of the current definition of XDR, since levofloxacin is a group A drug, this called as XDR-TB itself. In any case, the report was sent to her chest physician in Mumbai from the lab in Hyderabad. And based on the report from our lab, the chest physician in Mumbai started her on bedaquiline treatment. Now, she received this regimen, which I'm sure is very familiar to all of you, which included supervised administration of TAB BDQ 200 milligrams on alternate days. Okay. Now, what was the outcome of this treatment? She had rapid systemic improvement. She started having weight gain, her fever went away, and her chest symptoms improved. However, we could not save the eye. There was total corneal melt. So what you're seeing here in the black area is where the cornea has completely melted, and the gel of the vitreous gel is what is protruding outside the eye. Now, since the eye had been completely lost, we had to eviscerate the eye, which means that we had to remove the entire contents of the eye. Okay, so we kind of lost the eye while saving the life of the patient. Okay, now, of course, this, as I told you earlier, this was a 21-year-old girl, and cosmesis was important. It would be important for anyone, but for her, it was probably a little more important. So this is what we did for her. We got a customized ocular prosthesis. You can see the prosthesis on the left-hand side. The color of the iris here has been matched exactly to her other eye. And you can also see the blood vessels which have been drawn on the prosthesis, again matching the other eye of the patient. So the eye that was otherwise would have looked like this, which you see in the top picture, the patient could lead a life with both eyes looking very similar, and in fact also having some movement in the eye with the prosthesis. So this is, we could not save the eye, but this is what we could do for the patient. Now, we did not stop there. We were lucky that the aqueous sample also grew Mycobacterium tuberculosis. I don't have the pictures here, but we sent the cultures, thanks again to Dr. Sumalata, to NIRT Chennai, okay, for phenotypic DST. Now, this is probably one of the very few centers in the country that has this facility for the entire 23 drug regimen of anti-TB therapy for phenotypic DST. And we found that only 5 of the drugs were sensitive to this particular patient. And based on this, this is how we modified the treatment. And this treatment was continued. The patient has completed nearly 15 months of follow-up now. She systemically, she tells me, of course, she has not followed up with us now. She lives in Mumbai, but she tells that, systemically she has recovered completely. That's what her doctor has told her. And, there is no problem with the other eye for now. So just a brief, discussion on XDR-TB. I'm sure you're familiar with this, but XDR-TB is one that, based on the WHO updated definition of 2021, which fulfills the definition of MDR or rifampicin resistant TB, but is also resistant to one fluoroquinolone and at least one additional group A drug. So that additional group A drug was found because our patient was also resistant to moxifloxacin and linezolid. So based on this, we called her XDR tuberculosis. So these are some of the studies that are available from India on drug resistance in extrapulmonary TB in general. There are very few in literature if you look at it, large-scale studies, and a couple of them I'm discussing here. This one is from 2015 NIRT, and you can see the percentages in different forms of extrapulmonary TB are actually quite small. Then this is a study from AIMS, again published in 2015, where roughly 3% of the treatment naive and about 15% of the treatment experienced patients of extrapulmonary TB had MDR-TB, and only one was diagnosed to have XDR-TB. Then there's this study from my alma mater, the Nair Hospital, TN Medical College in Mumbai. And this study shows a much higher percentage in the case of spinal tuberculosis, where up to 30% of the samples were drug resistant. And based on the definition of XDR prevalent at that point of time, 4 of the 43 patients were found to be XDR-TB. That's a fairly big number for spinal tuberculosis. So I am suspecting that the prevalence of MDR-TB in general and XDR-TB in particular in the extrapulmonary TB population might be grossly underestimated, probably because the samples available are relatively fewer, and it is the endpoints of treatment are more difficult to estimate in extrapulmonary TB as compared to pulmonary tuberculosis. So with this, I summarize my talk that the treatment response in ocular TB can be challenging, even in the presence of coexisting pulmonary TB, as was in our patient. We should consider the possibility of MDR or XDR TB in non-responders to ATT, even in ocular TB patient. And there can be situations like in our case, where there's a clinical worsening in the eye, despite there being a favorable response to systemic TB. I thank you very much for your attention and acknowledge especially Dr. Sumalata and Dr. Shivakumar from NIRT Chennai, who helped co-manage this case, and Dr. Sanchita Mitra, Dr. Dilip Mishra, my microbiology and pathology colleagues, Dr. Somshila, my cornea colleague, and Dr. Tarjini Dave, oculoplastic surgeon, for helping co-manage this patient. Thank you very much for your attention.
Thank you, Dr. Soumya, for the excellent presentation and an eye-opening case for many of us who are not seeing regular EPTB, ocular tuberculosis cases. So just to summarize the whole case, those who have joined late, this was a case of a 20-year-old female. She was diagnosed based on gallinomatous panuveitis and Montauk's positive test in February 2021 with a significant history of weight loss, and started on category 1 treatment with steroids. But there was no improvement seen. So in May 2021, sputum gene expert was done, and that showed SRIF resistant, and hence the patient was started on second line ATT. In June 2021, the patient did not respond and hence reported to LV Prasad Institute. There, they saw that the patient has developed corneal perforations and aqueous humor tapping done, which showed AFB smear positive. LPA was done and which showed isoniazid rifampicin, levofloxacin, SLI resistant. Culture was also done, and DST shows sensitivity to bedaquiline, delamonide, moxifloxacin high dose, clofa, ethionomide, while resistant to other drugs. Patient drugs were modified, and after modification of the drugs, patient showed systemic improvement, but unfortunately, the eye got deteriorated and required evisceration of the eye. And thereafter, I think they did an excellent job by doing ocular prosthesis, and we all have seen the picture, and we cannot differentiate between the eyes. So this was a summary of the case. And I would like Dr. Shishir Narayan, because he's been expert into ocular tuberculosis, to throw some light into the case.
Thank you so much. Am I audible?
Yes.
First of all, I must congratulate Soumya for bringing ocular tuberculosis to the fore. We have had a decade of lot of struggle trying to explain to our colleagues, our physician colleagues, especially those who particularly specialized in tuberculosis, that we do have a very special entity of ocular tuberculosis, which is not really associated with systemic tuberculosis. So, this case really highlights that kind of a thing. And I want to bring out maybe all the things that Soumya said, maybe a few little points on each of them from my own experience. I was trained in Shankar Netrale, and the gentleman who trained me is Dr. Jyotirmay Biswas. When we thought of ocular tuberculosis as a cause, he did a very interesting study. He went to the TB sanatorium in Chennai, and he looked at 1,000 patients of pulmonary TB, those who were admitted in a TB sanatorium in his days, my teacher, and he looked at the ocular findings in patients of pulmonary TB. Very interestingly, there was only 1 to 2% of the patients who had uveitis. In other words, what you see in your day-to-day practice, you're seeing only tuberculosis largely. Those patients don't come to us because they are not the patients who get pulmonary TB, does not translate into ocular tuberculosis. It is a subset of patients whom Soumya very beautifully brought out, that 92% of the patients don't actually have pulmonary tuberculosis. And it is a paucibacillary disease which gets cleaned up or eradicated from the systemic circulation, but finds a good haven in the eye, because we have something called immune privilege or immune deviation, where any infection in the eye tends to have a kind of a privileged situation. Do you agree with me, Soumya, on that? So basically, what happens is that the paucibacillary disease then remains latent within the eye, which has been cleaned up from the rest of the body. And whenever the opportunity arises, either it comes in a hypersensitivity form, if the bacilli are very few, or it comes in a choroidal granuloma form if the bacilli are more. And definitely the incidence of the resistant TB, whether in the systemic area or in the eye, is going to be there. And we are going to face much of that problem. The second thing that Dr. Basu has beautifully brought out is that the biomarkers for the response to treatment are very confusing with ocular tuberculosis. The reason is that the eye is a closed system. And even if we are successful in treating the infectious component of the tubercle disease, the antigen remains sequestered within the eye, and it creates a kind of an immunological reaction. So after 2 or 3 weeks of successful anti-tubercular treatment, we suddenly have a paradoxical reaction. And paradoxical reaction means that a patient who has an infectious disease and is following the Koch's postulates should improve after the antimicrobial treatment. Why should he worsen if the patient has got the correct treatment? The reason is the antigen gets released, it's sequestered there, and it throws up a very severe immunological reaction that then requires a very high dose of immunomodulatory treatment to save the eye. So it is very difficult to know whether we are dealing with a paradoxical reaction or we are dealing with a resistant TB in cases which respond initially and then stop responding. And that is what Soumya has beautifully shown in this case. So these are my few points, and I would say it's been very beautifully brought out by Soumya.
Thank you, Dr. Sisri. I would like Dr. Sumalata, who has been the backbone behind diagnosing this case and reaching to the right stage. Ma'am, please.
Good afternoon, ma'am. Am I audible?
Yes, ma'am.
Yeah, thank you so much. Firstly, I thank NITRT for giving us an opportunity to present this case in this platform. And special thanks to Soumya sir, who is also a part of our DRTB expert panel in the state, and who was also part of building up the index extrapulmonary guidelines in 2015. So in the private sector, collaborating with the public sector in terms of diagnosis. So especially from other specialties like eye, bone, other specialties coming, getting their diagnosis. So this was very special to us because we got the DNA readily available to us and get the LPA done. So when Soumya sir brought to us, let us have this first line and second line LPA with the DNA available. So I was very worried that if the aqueous humor sample itself will be very small and it will be very difficult. But he assured that the DNA is already prepared and then sent the sample. And again, I will actually thank NIRT Chennai because they have done the entire array of DST for this special case. Then only we could come to the diagnosis of XDR. That was the point of change from the previous guidelines to 21 guidelines, that XDR definition has been changed. Till that point of time, if you see for the first line LPA, second line LPA, at that point itself, it is an XDR. But as the guidelines changed then itself, and we had to do the DST for linezolid also, then we had to depend on, even we want the newer drugs also, then we had to send the sample to NIRT Chennai. So they were kind enough, and we came to know that linezolid was also resistant. So, this was very exciting to us. And thanks to all the DRTB expert panel, this was also discussed in our state DRT, difficult to treat clinic. But we wanted more discussions and more, opinions, because ocular TB is not always discussed. And whenever if you see the statistics also, it is very less among all the extrapulmonary cases we do come across. So, and there are very few studies which says hardly 1 to 4% or 1.4% of extrapulmonary cases would be ocular TB. So, so is a low, and we do not know, and getting them diagnosis on and putting them on treatment is really, very, it was very encouraging to us, and it was very good for us. So when we came across this case, but it was, we were like doing the expert and getting the diagnosis. But this particular person was not residing in our state. She was staying in Mumbai. So her treatment was to be, again, her treating physician was residing in Mumbai, and her diagnosis was all happening here. So we had to, get the balance of both the things. And as soon as the diagnosis was made, we immediately communicated to Soumya sir, and he ensured that her treatment is started in due time. The sad part is she lost her eye because of the corneal melting and other changes that happen in her eye. But the diagnosis and the treatment and the way she is improving, it really gives us a good feel about the service we rendered to that particular person. I would also thank Dr. Subhakar sir, who actually pushed me to present this case in this NITRD Echo Clinic, who is our zonal task force chairperson and also my personal guru in terms of pulmonology.
Thank you, ma'am. Thank you, ma'am, for sharing your experience and for the wonderful diagnosis of the case and treating the patient. Now it's open for open discussion. I think Dr. Sennath is there. He has some questions. Unmute him. Sir, you're muted.
Sir, kindly unmute, sir.
So you're not audible. Please unmute yourself.
Sir, please use the microphone icon you have on your mobile side, left and right. On the bottom left side, sir, there is a symbol of microphone. Just tap on it to unmute yourself so we can hear you. So maybe there is a notification dialog box open on your screen right now to unmute yourself. Sir, you are on mute. In case you are saying anything, we are not able to hear you right now. I am requesting you to unmute. Just check your screen on Zoom platform. There is a dialog box which is asking you to unmute yourself.
Sir,
Hello, sir. Am I audible?
yes, Dr. Rishi.
Yeah, sir. Sir, of all, this case is a very interesting case. And when I saw this on the my mail, I sent this on my WhatsApp group to all the pulmonologists of UP, saying that you just take the also help the join to the Department of Ophthalmics also. So you, in collaboration with the Department of Ophthalmics, should also listen this case for the benefit of ocular TB treatment in UP, because the incidence of ocular TB in Southeast Asia, in North India, is very high as compared to South India, as per the 2004 diagnosis, sir. So this was my concern. And sir, I have two questions. Is that if one eye is infected, are there any chances that other eye may also be infected? If a patient of a lupus vulgaris comes on face, and if one eye is infected, are there chances that other eye may also be get infected if the treatment is done at right time? The other question is that there is also a test called multi-target PCR, which we do for vitreous chamber. Three target genes, IS610, MBB64, and protein B. So are these tests being done in a super specialty hospital of ophthalmics in India, sir? And this, my third question is that if we are giving drugs, second-line drugs, which also have linezolid and also in replacement ethambutol. So can these drugs be given in a patient of ocular? Thank you, sir.
I think Dr. Shishir and Dr. Basu can answer his questions.
Dr. Shishir.
Sir, I agree with you. We are doing routinely now the PCR for the two antigens that you have said, MPB as well as the IS1. And the small labs are not doing because we have got a very small sample. So there are dedicated large centers now in India, the LB Prasad, where Dr. Soumya Basu is there, Shankar Nethrale, where we've been all trained. So these have got very dedicated labs where we send, either they take out the specimen themselves, or we can take out the specimen and send it over, courier it to them, and they are doing, routinely been doing for at least the last 10 years, we have been confirming our patients of suspected ocular tuberculosis with a PCR with these two antigens. Yes, Soumya?
Yeah, I think these are very, very interesting questions, and I'm happy that they have come from a pulmonology colleague. So I'll take the first question, and it's also the most complicated one to answer. If we treat with TB therapy, what are the chances of recurrence in the other eye? And I would also add, what are the chances of recurrence in the same eye?
Perfect.
Now, we have had very interesting experiences, and all of this happened because till end of 2020, I was in Bhubaneswar for almost 15 years. I was at the LV Prasad Eye Institute in Bhubaneswar. And over there, you know, we have had patients where we have treated with anti-TB therapy alone, no corticosteroids, okay? And with that, we have seen complete resolution of, let's say, a choroidal granuloma. I'm not talking about the kind of patient we saw in today's case, but a choroidal granuloma resolving completely with anti-TB therapy. And the patient comes back a year or two years later with another granuloma, and we treat it with anti-TB therapy first line, okay, again, and it goes away again. So one thing we are sure that the first line therapy alone is working. It is drug sensitive, and there is no corticosteroids, which is, you know, adding to the anti-inflammatory resolving the disease. So there is a strong possibility that there are niche tissues in the eye that can actually harbor Mycobacterium tuberculosis, which you do not see in, for example, in the lungs. Okay. Now, one such niche cell type in the eye is called as the retinal pigment epithelium. This is the layer that lies just below the retina and above the choroid. So this lies between the retina and the choroid, and there have been multiple studies that have shown both in animal models as well as in human eyes that the retinal pigment epithelium can harbor the Mycobacterium tuberculosis. Not only that, when we compare its phagocytic abilities with macrophages, it shows that they are as good as macrophages in phagocytosing Mycobacterium tuberculosis when they are tested in the lab, but they are not as good as macrophages mycobacteria. So both have a nice ability to together where neither the RP cell dies nor the mycobacterium dies, and both live happily within the eye. Okay. And while this may respond to the anti-TB therapy, there are times where they recur again and they're treated with the same treatment and they go away. So this presence of these niche cell types can lead to a recurrence in the other eye despite there being a successful treatment in one eye. That's a very complicated answer to your first question. The second question about PCR, I think, has been answered well by Dr. Shri. We have been routinely doing tests for IS, the different genes, more IS610 and MPB64. We have seen that in North India, IS0 works very well, whereas in India, including in our center in Chennai and in Hyderabad, the MPB64 works better for PCR. But there is also a problem with PCR, which we had reported a few years ago. It is the presence of bystander mycobacterial DNA within the inflamed tissues. So this has been reported, for example, in autopsy specimens as well, that people who had nothing to do with TB all their lives, when you look at their spleen, their liver, you can see cells which are containing mycobacterial DNA. So these DNA can also be found in inflamed tissues of the eye. And we actually collected samples from a kind of ocular infection, which is called as endophthalmitis, which is a very deadly post-operative infection. And from these eyes, we collected those pus samples, and these were all culture proven to be some other infection, streptococcus or something. And 16% of these endophthalmitis patients actually had a positive PCR for Mycobacterium tuberculosis. So this shows the possibility of getting a false positive PCR. We're always worried about getting false negative PCR in ocular samples, but there is also a very strong possibility of getting false positive PCR in the ocular samples. So I think this is the reason why PCR is not an integral part of the index TB guidelines. Not only because it's not available commonly, but also because it has these issues of both false negative and false positive results. There was a third question which I don't recollect.
What's your third question, doctor? Can you repeat the last question?
Yeah. Sir. Yeah. Sir, the third question is that if a patient of ocular TB has to be given a second-line drugs with the replacement sequence, we have linezolid as well as ethambutol, and both are cardiotoxic. So, yes, sir. So, can we give these drugs in ocular TB?
Yeah.
If they are not resistant.
Can I take this, Shishi?
Yeah, sure, please.
Yeah. So linezolid is very rarely used for the ocular TB patients, but I have a point to make about ethambutol. And as you know, since the time the revised guidelines came, ethambutol is being used for the maintenance therapy as well. Now, what we have seen, and we have also reported, now published this literature as well, that at the LV Prasad Eye Institute in Hyderabad, just our center alone, the rate of ethambutol toxicity post 2018 has increased 4 folds of what it was pre 2018. So you can imagine the damage that ethambutol in the maintenance phase is doing to the eyes in our patients. So we do use ethambutol during the intensive phase, the first 2 months, but we definitely advise against using it during the main.
This Dr. Basu is talking not about patients of ocular TB, but about patients of systemic tuberculosis who have been given extended period of ethambutol after the neo regimen. In fact, we were so anxious as an ophthalmic community that we did a survey, right, Soumya? We did a survey among the ophthalmologists whether we would be happy with the pulmonologists giving an extended treatment with ethambutol. When it comes to treating ocular tuberculosis, what happens is a very common component of the inflammation in the eye is the disc edema. So we routinely find disc edema, especially in young people, whether we are dealing with choroiditis or we are dealing with anterior chronic granulomatous intermediate uveitis. So we are very, very particular in informing our pulmonologist colleagues, our physician colleagues, to at least keep a lower dose of ethambutol if they are going to give an extended treatment. And especially for ocular TB patients, we try to stop it as soon as possible. You agree, Soumya?
Yeah, I agree completely with you. Yeah. I mean, I know these are not kind of decisions that we sitting in this forum can take, but at least, we as ophthalmologists could make our pulmonology colleagues aware of the enormity of the problem that we are seeing in the eye clinics all over the country. And this is everywhere, not just in tertiary care center like LV Prasad, but also at Shroff Eye Center. You go to a small clinic anywhere else also, it's all across.
Thank you, sir.
And one point made was that ocular pulmonary tuberculosis forms only very small percentage of cases of pulmonary TB. But if you come to our uveitis clinic, probably 30% of the patients in India have some or the other form of granulomatous uveitis. When we see a patient of uveitis, we put the patient on a slit lamp and direct ophthalmoscopy. And Soumya said very clearly, we are the people who are directly seeing, as if we call it biomicroscope. Our slit lamp technically is called a biomicroscope because we are actually seeing the magnifications we are using is 25 times, and we are actually seeing the cellular reaction. And believe me, 25 to 30% of the patients of ocular inflammations have got some form of granulomatous uveitis. Soumya, refute or agree?
Yeah, I mean, maybe that putting a number like 25 to 30 may not be appropriate because there are so many factors involved and the guidelines are getting updated all the time. But we all agree that there is a very significant proportion of these patients. There's another, since we're talking about prevalence, I would want to highlight one very interesting fact for which studies have not been done in India, but there are studies available from both TB endemic and non-endemic countries. So around May of last year, there was a study that came out from the NIH in the United States, where they showed that the prevalence, if they tested all their uveitis patients in the clinic with a quantiferon TB Gold test, then 15% of all their uveitis patients in a TB non-endemic country like the United States had a positive quantiferon TB Gold test. Whereas if you look at the general population in the US, only 5% of the general population in the US has a positive QTB test. So, and definitely not all the 15% had ocular TB. They had, so many other types of uveitis, but still 15%, less than 1% actually had ocular TB, but 15% had a positive QTB. So the other interesting thing, and this is only a food for thought, where we are currently engaged in a lot of research, is how is the Mycobacterium tuberculosis, playing a role in inciting intraocular inflammation in those eyes. There must be some reason, because this was not just seen in the US. There are exactly similar studies done in the Netherlands, in Thailand, in Indonesia, and invariably in all these countries, both TB endemic and non-endemic countries, the prevalence of positive quantiferon TB Gold test was many times more than was many times more than the prevalence in the general population. So we are currently investigating how is it that, you know, MTB infection in the body plays a role in inciting intraocular inflammation. Now, again, taking one step further, we have very interesting mouse models of uveitis, where we inject retinal antigens into the foot pad of mice, and we can see uveitis in the mice. Now, what happens if you just inject the retinal antigens alone in these mice? Then they do not develop uveitis. You have to inject along with the retinal antigens something called as the complete Freund's adjuvant. The complete Freund's adjuvant contains heat-killed Mycobacterium tuberculosis. And only when these are injected together do you get uveitis in the mouse eyes. So definitely there are ways in which TB plays a role in inciting intraocular inflammation other than a routine tubercular infection of the eye.
Thank you, sir, for the extensive explanation. We do have some questions in our chat box. One is from Dr. Sayanath. He's saying that they have a patient, 22-year-old female patient, diagnosed with choroidal tuberculosis and had remission now and recurrence of symptoms. Choroidal biopsy was done, which was sent to IRL, Bloor, and Shankar Netralaya, Chennai. But unfortunately, it was reported as MTB not detected. Now they're facing how to go about this patient. The sample was precious and it shows MTB not detected.
Yeah, so, you know, we first of all, we have to be very careful in processing these samples for the DNA isolation, if it is DNA that we are looking at. But in these kind of cases where there is a recurrence after complete remission of the intraocular inflammation, one thing that we need to be at least aware about is the possibility of atypical mycobacteria. There are several reports available now which have shown that, you know, some of these lesions which appear exactly like ocular TB could also be due to atypical mycobacteria, and it's a huge challenge treating those lesions. But, you know, coming back to the question, there can be several reasons why MTB could not be detected either on smear or on culture or by molecular tests from the sample given.
Hello, sir. Can I speak, sir?
Yes, sir.
Sir, I'm Dr. Sainath from Mysore, sir. Thank you very much for your wonderful talk on the eye tuberculosis, sir, which you are almost in darkness. So this patient, she was referred to me from Bangalore, Narayana Netralaya, sir. Dr. Padma Malini had referred to me. She had given a course of rifampicin sensitive drugs for a full course of 9 months with steroids. Initially recovered completely. Her main symptom is severe throbbing pain in the eye. Again, they did this one, and she only sent the choroidal biopsy to IRL lab Bangalore, and also she sent to Shankar Netralaya. Unfortunately, as I told, it is now MTB not detected, but madam feels that it is still tubercular lesion. And now, as it's the guidelines, again we are started on risk sensitive drugs. So every 10 days or 15 days, patients calls me and, sir, what is the report? What I have to do? I have no answer to tell, sir. But now to diagnose MTB, NTB also. So what is how to go ahead, sir? No pulmonary lesion or anything except ocular lesions.
Dr. Shishi, you want to answer?
So I just want to say something, that when we are treating ocular tuberculosis, we are not treating tubercular infection. We are treating the tubercular the infection and its host interaction with the patient as well as with the eye. That means
we are not just treating with antimicrobials and that's the end of the problem. No, the release of the antigen, even the dead microbacteria can incite a very, very severe reaction called paradoxical reaction. So you may sterilize the infection, but unless you sterilize the inflammation because of the presence of antigen, you may still continue to get the inflammation there. And that's why we sometimes go ahead, do something called complete vitrectomy. We remove the entire vitreous jelly from the eye. We clean up because we want to remove the antigens. So paucibacillary disease behaves differently from multibacillary disease. And the behavior is not just based on whether it is resistant or not, but the release of antigens and the host response and the immune status of the patient. Everything then finally decides how the eye is going to behave and how the patient is going to behave. Somewhere?
Yeah.
Sir, this
so-
is referred from Narayanan Etra, sir. One of the best centers in Bangalore.
Yes, it is.
Ophthalmic centers.
This is the
Padma Marini
dilemma.
is in charge.
Professor,
So-
the dilemma that we face between infectious and non-infectious disease, and this is the non-infectious manifestation of the infectious disease. It is like treating COVID with tocilizumab. Why would you treat an infectious disease? Because then the host response comes in, and that time you have to take care of that rather than the primary infection. So, ma'am?
Sir, yes, sir. Yes, sir told how to diagnose the NTM, NTB, non-tubercular infection in ocular disease, sir.
So
what sample I have to send?
NTM is
NTM, sir.
unfortunately a very under-recognized condition in uveitis. We
Yes.
do treat a lot of ocular surface infections with different NTMs. Those are very common. We are able to get a sample. We have microbiological evidence. That is very common. But to get the evidence of NTM from the intraocular inflammation is very, very difficult, and that's why it's very, very under-recognized. And I'm probably not the right person to answer there, but one thing I can say that, the way forward is to look at molecular diagnosis of NTM. That's first of all to suspect it in the right cases, and then go for the molecular diagnosis of NTM. That's the way to go about.
Thank you so much, sir. We have.
Thank you, sir. I thank sir. Sir, I thank Singla sir for sensitizing.
Thank you, sir. Sir, we have another question from Professor Sakin Hemad from Bangladesh. He's asking, how long do you treat ocular TB with ATT?
Yeah, so this has been a long debate in the ophthalmic community. I can tell you that majority of the ophthalmologists, and this is also mentioned in the ICMR guidelines, who treat for at least 9 months. That's the guideline. But I have been treating, and I can quote at least one other important uveitis expert, Dr. S.R. Rathinam from Arvind Eye Hospital, Madurai, who has been treating for these patients for 6 months alone and with very good results. The current literature available does not really give good evidence whether 6 months is better than 9 months or vice versa. So we are currently involved. We are currently involved in a multi-centric studies, mainly from our center in Bhubaneswar and a center in Burma, in Yangon, Myanmar, and centers in Indonesia and Thailand, Bangkok, Thailand. So these are 4 major centers where we're doing a multi-centric study, long-term, over 5-year study, where we are looking at a randomized controlled trial between 6 months and 9 months of therapy. It will probably take another couple of years before we are able to publish the results, but hopefully we'll be able to settle the debate about 6 months versus 9 months.
Also, in hindsight, we have the advantage of seeing the patient every 15 days to 1 month. And we have the clinical parameters, the OCT scans, the retinal vasculitis. We can see how the patient is responding to treatment. So we are actually able to titrate our treatment based on the clinical response as well. And sometimes we even extend it to a year in patients who are slow responders.
Thank you so much, sir. I think we had a good extensive discussion on tuberculosis today, and it has definitely enlightened us and increased our knowledge. Now, like at the end of the session, I would like Professor Dr. Singla sir to give his opinion and on this case.
Thank you very much to all of you, especially Dr. Basu, Dr. Sharaf, Dr. Samlata, and the entire team who helped in diagnosing and treating this case. You see, I got various messages from this case. As per the court study, as Dr. Basu informed us, 92% of ocular TB cases had no active TB. 77% had no past history of TB. 31% have no X-ray signs of TB. So that means it puts another challenge to the eye doctors who are treating the ocular TB, whether suspect or a confirmed or. So in these cases, how to diagnose, how to confirm whether they are dealing with TB only or not. And not only that, you see even ruling out drug resistance in TB, like even in this case, initially for 2-3 months, patient was on drug-sensitive TB treatment because there was no evidence as such to think of drug-resistant TB. Patient even was requiring steroids locally as well as intravenous. He was given that, and if he had this drug-resistant TB, it can flare up in absence of getting treatment for the drug-resistant TB. But there is no way to rule out this. Fortunately, in this case, patient had lung TB. Sputum examination was done, which by genotypic methods, which showed that patient is having drug-resistant TB. So soon patient could be shifted to the drug-resistant TB treatment. But it may not happen very often. It may be very unusual to have this. And I remember especially Dr. Shishir has a habit of whenever he is treating ocular TB, he sends it to us or to some other people to rule out lung TB or to confirm whether it is TB or not. And that puts a lot of challenge on us, that how to, in this case, to rule out or confirm active TB, because many of them, they have no other sign of TB, especially in the lungs or somewhere else. But good part is, I've seen people from especially the Sharaf Eye Center, they're looking for TB elsewhere. They are doing X-ray chest. They are doing the Mantoux and the interferon gamma. They're even doing the CT scan. And whenever there is such evidence which is suggestive of TB, even bronchoscopies and bronchial aspirate has been done. And I remember a few cases where bronchial aspirate had shown TB plus drug resistance TB, so that the treatment could be modified at an appropriate time. So I think even to the chest physician and even to our ocular colleagues, this message is very clear, although uncommon to have the associated lung TB, but we must make all the efforts to look for associated lung TB where it is easier to get a sample. Obtaining a sample from ocular TB, we all know that it is very, very difficult, and even an ocular surgeon will think 10 times before approaching the ocular TB case to obtain a sample. So in case you are investigating in the lung TB and you find it is there, then whether by sputum or by doing the bronchoscopy and bronchial aspirate, there are high chances that you may get the presence of TB as well as you are able to rule out TB. And one thing more, you see, usually we say these are paucibacillary diseases. They are all extrapulmonary TB are paucibacillary, including the eye ocular TB. Still, why are we having this kind of drug resistance TB like in given case? I feel most of the time it is the contact who must have had drug resistance TB from whom this patient acquired the infection. Otherwise, normally the drug resistance is directly linked to the number of bacilli which are present, because drug resistance develops by spontaneous mutation. More the number of bacteria, more the chances of number of bacteria having spontaneous mutation, which is associated with the resistance to either INH or rifampicin or both, or to the other drug. So most probably this person must have had contact with a case of drug resistance TB from which she acquired the drug resistance infection, and which unfortunately in the 2-3 months in the earlier part could not be diagnosed. And later, by the time it was diagnosed by the sample, then it was little too late that she could respond. Although systemically she responded, but we lost the eye. Now, regarding the ethambutol in the continuation phase, you see earlier the treatment regimen was you give 2 months of 4 drugs, INS, ethambutol, ethambutol, paracetamide, and then after 2 months you do this sputum smear. In case it is positive, you extend the treatment by another 1 month, and then in case it becomes negative, you shift to the INS. But now, ever since the new WHO guidelines came, ever since the genotypic tests were available, combining these two evidences, the call was taken in our country that after 2 months, in case somebody is smear positive, you do the genotypic test, rule out rifampicin resistance. In case it is not there, you shift to 3 drugs, INS, rifampicin, ethambutol. Why 3 drugs? Because it has been recommended by the WHO guidelines that in countries where initial resistance to the INH is more than 5 or 6%, there to prevent resistance to the other drugs and for a better pathological response, you give 3 drugs in the continuation phase. But now, as we hear our ophthalmological colleagues, that ever since 3 drugs have come into the picture, the incidence of the ocular toxicity has increased. So I think that that experience should be kept in mind whenever we are revising the guidelines, that in which cases to give 3 drugs in the continuation phase and whether the 2 drugs are good enough. But definitely one thing is clear, that in case you want to give ethambutol for the entire 4 months in the continuation phase, dose should be reduced. Like say 50 milligram per kg dose, initially you can give 20 or 25, but in the continuation phase, 50 milligram per kg dose should be reduced to prevent this ocular toxicity. And another thing which we learned was that whenever you are obtaining a eye specimen, it requires a different method to isolate the DNA. This, I don't know how many of us may know it. So it is good that they isolated the DNA themselves and then submitted it to the laboratory for further genotypic tests. So I think that also should be kept in mind by all our ocular colleagues and by our chest physicians, so that they can guide their ocular colleagues that in case you are looking for this, you should do this. Definitely as somebody asked, the diagnosis and management of NTM in eye, I can imagine how difficult it must be. Even for lung TB, we find there are very, very few physicians who have experience of treating the correct way the NTM infection. Very few labs in the country which are able to do the culture, species identification, and followed by the DST for the NTMs. Because especially at least for the rapid growers like Fortune, Mepsis, Chinoi, we need different kind of treatment, and for the slow growers and others, there is different kind of treatment. So it is always better to treat them in case you have the NTM species identification and also the DST to be there. And for eye, because the sample is not there, so you're not able to do culture, not able to do the species identification or the DST, it must be a great sample. So that was also discussed today. Regarding the length of treatment, yes, it is usually 9 months, as our colleagues told us, and there are some people, as Dr. Basu claimed, that they are giving for 6 months with good results. So once they publish this kind of data, only then the index TB guidelines or the country guidelines can recommend that even 6 months may be enough. Like for most of the extrapulmonary TB, we are recommending 6 months, other than CNS TB, etc. So with these few points, I must thank all my colleagues, Dr. Basu, Dr. Shishir Narayan, and the motor colleagues, Dr. Kandi also, who he was the person who coordinated the entire show to bring he said he has he's the executive chairman, and he said he is a very interesting case of ITB. So we jumped over it, that why not to learn ITB, especially when it is from a place like Abu Prasad Institute, and they've done every possible thing to diagnose this case. Thank you, Dr. Kandi, also. With this, I go back to Dr. Saroj for carrying it up.
So first of all, I would request each one of you to kindly go to the link which has been shared in the chat box for feedback and give us your feedback, which will help us to improve further, and I think it will help us everybody. Sir, I would like to welcome Dr. Shubhakar Khandi, and he wants to say something. Sir,
Yeah, I think I must congratulate Dr. Basu for bringing out an important and interesting case. So all these years, ocular TB is only a clinical diagnosis for us. Getting a microbiological diagnosis is not common. That too, a microbiological diagnosis of drug-resistant ocular TB is more interesting. And when I heard this case, I have an opportunity to meet Dr. Singla at Vijayawada. Sir, we will next month we'll have this case. It's an interesting case, and he has readily agreed to this. And I must congratulate Soumya Basu for bringing an interesting case, and they have done good work of oculoplasty. And I could not, unless he said that I have done oculoplasty, I could not see which is the eye, normal eye, which is the oculoplastic eye. Then coming to some of the issues which were discussed already, Singla has answered some of the issues. I want to, regarding the duration of the treatment, there is no hard and fast rule. Only the guidelines are only to guide you. The optimum duration is 6 months. If the patient is not responding, it is the clinician has to take a call whether you have to extend duration to 9 months or 12 months. That is all depends upon the treating physician. And one more thing regarding the INH, the ethambutol in the continuation phase. Fortunately, unfortunately, I am involved in drafting those guidelines, including the ethambutol in the continuation phase, because there is a robust data in India. The most of the drug resistance TB is due to giving only INH and rifampicin in the continuation phase, where there is a 15 to 37% of INH resistance. INH resistance indirectly leads to rifampicin resistance. We are creating a factory of MDR. So there is a scientific data that to include ethambutol in the continuation phase. But Soumya Basu is telling that he is seeing a lot of vision abnormalities after this guidelines change. I request Soumya Basu to, instead of telling that, you let them publish this data, because we have India is a country where CKD is more common. Without evaluating for CKD, if you give ethambutol in normal doses, then it can lead to the visual abnormalities. So in initiating ethambutol, I think you have to see whether the patient is having other chronic kidney disease, other things, already has a pre-existing eye problem. Those things you have to look. Of course, in routine program, you can't do this, but I think it's an interesting information. It is the right time to think over whether to reduce the dose before giving ethambutol. You have to rule out whether there is any chronic kidney disease is there, where the ethambutol is not excreted. There is a toxicity leading to ocular abnormalities also. We have to look in. Without having this data, I think now the program, we can't change the guidelines that saying that Soumya Basu is seeing some visual abnormalities. I think it has to take a call on this at a national level. And if all the ophthalmologists come forward and publish their data of ocular toxicity with ethambutol without any renal disease, without any other coexisting disease, with a normal person having a problem, if the ocular toxicity is there, I think we have to take a call in reducing instead of 25 milligrams per kg body weight to 50 milligrams per kg body weight. I think one more issue is NTM was very discussed. I think now the government of India Central TB Division also is coming out with the new guidelines of NTM, and now we have to do a culture, and the culture facilities are not available everywhere. And Soumya Basu hinted about getting a molecular testing. Now the molecular testing right now not available for NTM. We have to explore that also. And with this, I really, I'm very much fascinated to hear the talk of ocular TB from Soumya Basu. I'm very happy that this is from the Hyderabad.
Thank you very much.
Thank you.
Thank you very much, sir. Now we are running out of time and would like to close the session. We are sorry if we are not able to take anybody's question here, but I think the discussion and explanation was quite extensive, would have explained each one of us doubt. And there's always a next time, I guess. You can always mail to us, we'll reply back to the mail. Thank you so much. Thank you, team Eco India, for conducting this session.
Thanks, Professor Shingla, for inviting me. Thank you very much.
Thank you.
Thank you, sir. Thank you so much.
Thank you very much for giving me this opportunity to interact with you. Bye-bye.
Thank you, sir.
Thank you. Okay, bye.
Bye-bye.